Let's now resume our session 5. And for that, I'm delighted to invite on stage our chairpersons, Dr. Vinayendra Pamecha sir, Dr. Kalyan, Dr. Charles Pinnacle, and Dr. Naveen. Over to the chairpersons.
Yeah. Thank you. And for the next talk, may I invite Professor Soin. He needs no introduction. And he'll be talking on identification and management of early allograft dysfunction in LDLT. The floor is yours, sir.
Good evening, everyone. Thank you very much for the invitation. So, as living donor liver transplantation became more popular, we started discovering another aspect of allograft dysfunction, which had nothing to do with ischemia reperfusion, largely because as we had seen in deceased donor liver transplantation, if the graft was fatty, if the cold ischemia time was high, then you would have significant ischemia reperfusion injury sometimes. And sometimes the graft would not work. So then we got into the territory of saying that there was ischemia reperfusion injury or primary non-function of the graft. But with living donor liver transplantation, what happened was that the volume of the graft that has been transplanted into the patient has reduced. And at some level, that may make a difference. And of course, the cold ischemia time and warm ischemia time are pretty low. So the preservation times being low, the ischemia reperfusion injury as a phenomenon is much less. Fatty livers are generally much less prevalent in the LDLT situation because you don't take such donors that have more than 10-15% fat. So let's try and understand what is this early allograft dysfunction in living donor liver transplantation. So this has been defined in various ways by various authors, depending on their experience, but this definition has actually held sway over the others for the last 15 years. And this is when initially things go well after living donor liver transplantation. And then on day 7 or later, you get a rise in bilirubin. And then the INR initially after stabilizing may rise or actually fail to fall. And then early indications of this could be an aminotransferase level of more than 2,000 international units per ml in the first 7 days, usually in the first 3 days. And then there is this definition of small foci syndrome, which typically happens or may happen with small-sized grafts. And that usually happens with grafts which are less than 0.8. But I mean, there is a lot of conversation around what is an ideal GRWR, but let's leave that aside for the moment. So bilirubin of more than 5 and or ascites more than a liter per day, and this is usually in the second week. Coagulopathy, and of course, you have to exclude technical causes like vascular occlusion, outflow congestion, biliary complications, infective and immunological complications. So just keep these definitions in mind because these are the definitions around which we, even now, after 10 to 15 years after they were given, work. So I will build this talk around a case scenario because then it becomes easier to understand what happened to the patient and then what was our thinking in managing this patient and then what we did eventually. So this gentleman, basically 50-year-old person, had mast cirrhosis, high-age male, 23, CTP10. He had a right lobe graft with hemiportocaval shunt. His actual GRWR, graft to recipient weight ratio, was 0.68%, and it was predicted to be slightly less, 0.62 preoperatively on CT scan. His portal pressure intraoperatively was 26 millimeters of mercury. And then after reperfusion, after we did the HPCS, it was 15. Cold ischemia time was 89 minutes. Warm ischemia time was 32 minutes. He had 5 units of PRBCs, 4 of FFPs, and 1 apheresis. So standard living donor liver transplant. This is what happened in the first 2 weeks. His drain output continued to be high on, if you look at the bottom, then the drain output on day 8 and day 10 was around 1.5 to 2 liters per day. He remained hemodynamically stable. He was conscious, alert. His respiration was good. So if you look at the pattern of bilirubin, it kind of initially fell in the beginning from 8 to 4. And then around day 6, it started rising. And then it became, it went higher and higher. And by day 12, it had reached to 15, right? And the INR initially was high, and then it fell to 1.6, and then it started rising, and it became around 2.5, 2.6 on day 12, day 10, and 12. So obviously, this person is having some kind of allograft dysfunction. What are the causes of allograft dysfunction after liver transplantation, especially after living donor liver transplantation? It could be small for size syndrome itself, because I mean EAD is like fever. It's a manifestation, and it could have many causes. So one of them could be small for size syndrome, and the other is, of course, biliary complications, vascular complications, rejection, usually T cell mediated rejection or ACR, ischemia reperfusion injury, although less common in LDLT, and occasionally drug induced, viral, bacterial infections. Fungal infections usually happen later, and primary non-function, which is pretty uncommon in LDLT. So what we did for this patient, obviously we excluded all these things. So for sepsis, we did the usual things, and there was no apparent sepsis. There was no viral hepatitis. There was no bile leak. CMV, although early, was negative. We did do a biopsy, and I'll show you what the biopsy showed. There probably was small for size syndrome with a drain output of 1500 ml a day, and there was no vascular complication. This is what the biopsy looks like. You can see portal tracts. There are several of them. There are 3 of them in this, well, half of it here, 1 here, and a bit of it here. So basically, this does not show any clear T cell mediated rejection. What it does show is the whole biopsy showed 8 portal tracts, and there was mixed neutrophilic infiltrates. There was some ductular proliferation. There was no ductulitis. There was no endothelitis. There was no mononuclear inflammation in the portal tracts itself. And there was some mitosis. There was some cholestasis with feathery degeneration and bile plugs. And all in all, it was suggestive of perhaps some kind of cholestasis or cholangitis, right? So the interpretation was query small for size syndrome. Now, small for size syndrome is a syndrome. It could happen because of many reasons. It basically means that the functional volume of the transplanted liver is too low for what the recipient needs. So it could happen with, ischemia times being prolonged. It could happen with small GRWR or fatigue liver or inadequate venous outflow, high MELD, sepsis, excessive portal hypertension, low arterial flow, then shunts. So what you can, and then excessive portal pressure, excessive portal flow. Now, these can be dealt with by something called portal inflow modulation. And so when is portal inflow modulation indicated? we published this a few years ago, where we showed that if we followed this protocol where we did the portal pressure in the dissection phase, and if the pressure was less than 15, nothing was necessary, even though the graft volume was less than what was needed. And if it was higher, then based on GRWR, whether it was less than 0.7, 0.7 to 0.74, or 0.75 to 0.79, we did HPCS, hemiportocable shunt, and if the portal pressure was high in the moderately low GRWR grafts, then we did a shunt. If it was not so high, then we did a splenic artery ligation. And in borderline GRWR low grafts, we did splenic artery ligation. So with this, we found that all kinds of grafts of various GRWRs, less than 0.7, 0.7 to 0.75, and more than 0.75, had similar survivals to those which were more than 0.8. So this was a good protocol of portal inflow modulation. So what did we do for this patient? We obviously, so when patients who do not have a definable sepsis or biliary or vascular complication and no rejection, and they have graft dysfunction, what you need to do is largely let nature take its course. So you have to manage this patient in a way that they don't go into sepsis. And of course, specific medical treatment will be necessary at times. So you have to prevent sepsis, you have to give them good nutrition, and you have to manage immunosuppression in a way that they are getting moderate immunosuppression. We generally, if the renal function is good, we generally keep the TAC levels to around 5 or 6. So what are the other specific treatments for early allograft dysfunction? N-acetylcysteine? Not really. It's too late for this kind of, for N-acetylcysteine, and there's very little evidence. Again, prostaglandins, not at this stage, on day 10 to 15. Too late, little evidence. Plasmapheresis, maybe. Delayed procedures like splenic artery ligation or splenic artery embolization by IR, or splenectomy, or TIPS, maybe there's a role for them. Conservative, of course, is the default way to go. And retransplant is best avoided because these patients often have an overlay of sepsis. Even if they didn't have sepsis to start with, they probably have some sepsis down the line before they recover. So the delayed procedures one can talk about are splenic artery ligation, TIPS, or surgical splenic artery ligation or splenectomy. There are small case reports and anecdotal reports of delayed splenic artery occlusion helping. So this is Abhinav Humar from, at that time he was in University of Minnesota, and they said that 6 of the 7 patients actually improved with IR or surgical intervention. That means splenic artery ligation. And this is a small, this is a case report on SFSs being treated by TIPS. What about plasmapheresis? So there is a huge body of, not very convincing evidence because they're not like head-to-head randomized control trials, but they are case control series, and there is case series, large number of patients, 76% graft rescue rates with somewhere between around 10 sessions of plasmapheresis for these patients. Another paper from the same group showed that with plasmapheresis, they had a 30% higher graft survival than without plasmapheresis in a group that was supposed to have EAD with a definition around bilirubin of 10 within 30 days of liver transplantation without concurrent biliary complications. So they had 107 in the plasmapheresis versus 36 in the no plasmapheresis group. And the 1-year survival rates of the TPE group was 1 month and 1-year survival rates were 82 and 53 and 58 and 22. So that was a significant improvement with plasmapheresis, but they gave a lot of plasmapheresis. There are other papers that refer to this with about 20 to 50% improvements in graft rescue rate with plasmapheresis. There are basically these 4 papers that I have compared. What we did was we did 5 sessions of plasmapheresis starting on day 13, and we found that eventually the bilirubin started falling. The patient did well. And if you remember, we had reports until day 12 on the previous chart, and this is day 13 onwards. And with these plasmapheresis done at 24 to 48 hours intervals, this patient gradually improved. And by day 26, his bilirubin was again down to 6.6. His INR was better, and he did well. He went home. So I'll summarize here saying that early graft dysfunction is not uncommon after living donor liver transplantation. And EAD or SFSS is diagnosed after excluding vascular, biliary, infective, and immunological causes. And recipient selection, portal flow modulation may help in preventing SFSS. And general support, nutrition, prevention of sepsis, and giving moderate immunosuppression is the way to go to manage these patients. Selected patients without sepsis can be helped with plasmapheresis. Our usual protocol is to begin plasmapheresis around the 2-week mark. If these guys have persistently rising bilirubin and that crosses 15, that's the usual kind of threshold when we start thinking of plasmapheresis. And so plasmapheresis may help. And prostaglandins or interventions by surgery or IR, there are some anecdotal reports of benefit. I've actually tried to make this whole thing very simple, because if you get into literature, you get completely confused on what it means and how people manage it. But I think you just take home the message, you exclude other known causes of biliary, vascular, immunological, infective issues, and just sit tight on these patients, and selected patients will be helped by plasmapheresis. Thank you.
Thank you, sir, for that excellent talk. And since sir has to leave early, can we have some questions now?
Sure.
The floor is open for discussion. Sir, can I ask you something?
Sure.
In spite of the hemiportocable shunt, this patient went on to develop a early allograft dysfunction. So is there any particular reason who are the patients who don't respond in spite of hemiportocable shunt? Are there any predictors?
So, I can't give you an answer that is based on data in terms of our analysis of risk factors as to who will and who will not do well with HPCS. You see, there is a complicated relationship between portal pressure and portal flow in terms of how you benefit these patients with portal inflow modulation. And it is widely thought that, well, actually, pressure is more important. It is widely thought that, but actually, I think flow is equally important. So, because there is, we've all seen those electron micrograph pictures of hepatocytes suffering within 30 minutes of hyperperfusion when you actually have a portal hypoperfusion. And that is basically like a flow phenomenon rather than a pressure phenomenon. But I think that flow varies so much between patients with different degrees of shunts, portal hypertension, graft size, that pressure is a more objective way of looking at things. So I think that the reason that this patient or patients who otherwise will have shunts and good pressures but still manifest SFSS, that will happen because of primarily two reasons. One is portal hypoperfusion because of excessive flows, and the other is an overlay of sepsis.
Hi, I'm Kalyan from Cleveland Clinic. Excellent talk. I think the portal inflow modulation is one of the biggest steps due to which we're now able to even transplant left lobe grafts, right?
Yes.
So at the time of the transplant, do you look at the portal flow, and if the HPCS wasn't enough, do you consider splenectomy at the time?
We've never had to do that.
Okay.
Because it's always possible to modulate the extent of portal pressure that you want to achieve. So what we do is that occasionally we've had excessive flows through the shunt. So we do the shunt after the hepatectomy and before the implantation, because we've already decided on the basis of the hemodynamic parameters before whether we're actually going to do it or not, and the basis of how sick the patient is and the graft weight. So we would do a shunt a priori. And then once we've done the shunt and we see that the pressure is, so we want the shunt flow to be between 25 to 40% of the actual hepatopetal portal flow. And if it is not that, and if it is excessive, you just pinch the edge of the anastomosis and you can actually modulate how much flow goes through the shunt and how much flow goes through the liver. So we do that.
And have you considered CVVH as a way to control the volume in the initial phases, in the first 5 days before?
We haven't done that. No.
Okay. So, okay. We do that in Cleveland Clinic, and the volumes, especially the drain output being so high, I think it is one of the indicators when the GRWR is low than the predicted. We do use CVVH for.
So you published that?
Huh?
You published that?
No, we're using it in clinical practice. We will most likely.
Yeah, look forward to that.
Yeah. I think. Great talk, Professor. But important thing is, I think GRWR might not be the key. It is the flow, basically. You all sometimes see these things happening with the normal GRWR also. But important thing is this small for size. I think it's the initial phenomenon which manifests later. What is your thought on that? Because many people say it's functional small for size rather than actual the GRWR. Initial injury which we see with the flow manifests in the second week.
That is correct. The initial injury does manifest later, but you see there is also the added complexity of, for example, if things are going well, it was a sick patient and you put in a 0.65 GRWR graft and you did a portal inflow modulation and you achieved the pressure you wanted and you had great going in the first 10 days, but then there's sepsis, right? And then what happens is, or there is, let's say, segment 8 congestion. So then your functional volume actually comes down, and then you will start having an overlay of small for size syndrome features, both clinical as well as biochemical. So then this picture gets obfuscated. But if you take it in isolation, what you're saying is correct.
So some of the centers nowadays, they use octreotide or beta blockers to reduce the portal pressure.
No, we've used it also. I mean, we've used both. Again, occasional benefit, but nothing that I can really confidently say here that you must do this. What I can confidently say is what I said, and also selective with portal inflow modulation. These things will be much more helpful than pharmacological intervention.
So, regarding these pressures, what we measure intra-op, there are a lot of dynamics regarding how much fluid. Some anesthetists use the restrictive fluid module, some are liberal. The other components are, there are a lot of collaterals. By the time these collaterals collapse, so there is another reason why in second week, some people start presenting as small for size. So our idea is not just to look at that pressure, but also to predict what can happen, whether these pressures, and the surrogate marker, which we felt when we were like evaluating these things, is we look at the spleen size, not just the pressure, but also the flow and the occlusion pressures as well of the portal vein. And that is helping us in deciding that how extra we need to go in modifying these. So even if the pressure has come down, we are on a lookout of these patients that we need to add some pharmacologic supportive therapy in these patients or not. Your thoughts on that?
Yeah, you see, like you said yourself, I'll just pick on the first part of your comment. And that is just, the whole thing is so complex with the collaterals and shunts. How can you predict which collateral will shut when? I mean, there's no way of saying that, right? All you can say is that because the initial dissection phase pressure was high, which is what we measure, and there are people who say that you should do a net pressure, because you have to account for how much CVP there is at the time that you're measuring the pressure. So that's a fair thing to do. So once you've measured the net pressure or the portal vein dissection pressure, that's obviously a marker of the degree of portal hypertension. And more the portal hypertension, more collaterals there'll be. Now, when they will shut, whether they'll shut in 3 days, 6 days, 20 days, 15 days, how many of them will shut? Who knows? So I think that what you're saying is there are many factors that control what sort of manifestation a patient will have with portal hypoperfusion at what day. But to predict it and actually preempt it with pharmacological treatment, I think that's an overstretch.
So what we found out that looking at the spleen size, dampening of hepatic artery, these were two markers. Whenever they start, I mean, if you don't react at that time, in 3 days or 5 days later, you see a drain output going
Yeah,
up
but
significantly.
you should publish that.
So we published the interior, the first part of the study. We are just collecting the
So
data.
Neerav and all published this net portal pressure story, right?
So that HPCS thing,
Yeah,
actually.
Yeah, no, in the sense that CVP minus the actual portal pressure.
Actual portal pressure
Yeah,
minus.
yeah.
But then he looked at the
No, the other way around. Portal pressure minus the
portal
CVP.
minus.
Yeah.
But then I think there are more variables to that. That is what.
Yeah. I mean, I think, see, when you have like 16 factors controlling something, then it's best to look at the important 2-3. That's my simple surgical brain. Thanks.
We're doing management of chronic rejection after liver transplantation and recent concepts. We invite Dr. Chowdhury.
Good evening, everyone. So, chronic rejection. Actually, when we look at liver, and we have been taught liver is an immunologically privileged organ. I mean, I would say it's comparatively immunologically privileged, but it is not that immunology privileged. And that the reason why I say that, there is a significant episodes of rejection which happens after liver transplant. So whether it is acute or chronic component of T cell mediated rejection or antibody mediated rejection, and sometimes, if you are unlucky, a combination of both attacking the liver. And this can present at various stages after the liver transplant. Although with betterment of immunosuppression over last 3 decades and understanding of immunosuppression and more data coming up, so we are able to bring down the overall episodes of rejection, but then it is still significant. Like giving an example, acute rejection in the range of 10 to 25%. The chronic rejection, which used to be one of the major cause of organ failure till 2 decades back, is now down to less than 5%, which used to be around close to 20-25% around 2 decades back. But then it is still a major problem, and that is the reason why we are discussing that. So what exactly is chronic rejection? I mean, when the word chronic comes, we think that something that is going to come a few years later, but actually this is a misnomer. The chronic rejection can happen anytime early on after transplant, and there can be a graft failure within 1 year after the transplant as well. And it is a combination of immunologic as well as the ischemic insult which happens to the liver. Immunologic insult damages the bile duct. Ischemic insult leads to blockage of the arteries, and which further damages the bile duct and leads to graft failure. As I said, the overall incidence has come down, but then it is still significant. And this is something which is going to go up again, because I'm going to talk about it later with the newer entity about chronic antibody mediated rejection, which is now being picked up by the tolerance study people, where they are doing biopsies in absolutely normal LFT patients post transplant, and they are picking up antibody mediated rejections in those. The important thing about chronic rejection is just to prevent it the best way, or if you have it, then diagnose it early when still some reversibility is possible. But if you diagnose late, the only option in those situations is either loss of life or retransplant. Now, to find out who are at risk of having chronic rejection, so whether it is a T cell mediated or antibody mediated, there are various risk factors which has been defined in the literature. Someone who's having recurrent episodes of acute rejection, they are at risk of having chronic rejection. Second is late anterior rejection. So late anterior rejection after, say, 30, 60, 90 days after the transplant, there is no defined definition, the timeline defined for late acute rejection. But the problem with late acute rejection is very high chances of it converting into chronic rejection. patients with autoimmune liver disease who are not taking immunosuppression properly, or the immunosuppression is not being handled properly, are the kind of patients who develop more of these kind of rejections. And then there has been data that the older donor, less MELD at the time of transplant, in cadaver settings, longer cold ischemia time, and retransplant done for immunologic graft failure are the common risk factors. Now, if you look at pediatric transplant data as well, so non-biliary atresia cholestatic liver disease, 2 or more rejection episodes that has been consistently shown in on pediatric database, these patients tend to have more chances of rejection. And then once these kids starts to get into adolescence or young adulthood, they start to play around with their immunosuppression, or at the time of having pregnancy and conception, they can have a rejection which can convert into chronic rejection. Now, what happens in these kind of situations, in particularly what I was talking about, late acute rejection, if it persists, that means there is a possibility that it's a combination of T cell and antibody mediated rejection, and the inflammation continues, leads to further endothelial injury and leads to ductopenia and vasculopathy, which is labeled as chronic rejection. Now, the late and acute rejection is slightly different from the ACR what you get in the early phase. Although if you look at pathology slides, the inflammation is not that much, but there is more central venulitis, and then there is formation of fibrosis around, and that leads to progression of the disease. So anyone who's having LAR, these are the patients, whenever you have a patient you are suspecting LAR, biopsy is a must, as we were discussing in last session as well. Don't treat any suspected rejection without a biopsy. Doing a C4D staining is important, and if you see a C4D staining positive, doing a DSA and look for a combination of the rejection. And these are the patients have a higher chances of steroid resistance as well. And these patients, if you just keep on treating with steroids, you might miss the bus and end up losing the graft. So if we talk about the overall presentation of chronic rejection, particularly T cell mediated chronic rejection, it can present with just deranged liver function test or a cholestatic pattern, or may ultimately present with a graft failure. Whereas the antibody mediated rejection, there are some patients you would see later on after the transplant, they start to have ascites again, and features of portal hypertension where you see a platelet count coming down. If you do a biopsy, you might see these findings of. So never ignore any new thing that is coming up, even if the LFTs are normal. And I'll show you later on data. There is, in pediatric data, 50% of the pediatric post-transplant patients who have normal LFTs have a significant DSA and can have features of antibody-mediated rejection. Only finding in those patients are just drop in platelet count. So all these things should not be missed. So any abnormal LFTs, any newer features which can be a portal hypertension kind of features should not be neglected. So other potential diagnosis which can present like this is drug toxicity or recurrent disease like PBC, PSC, autoimmune. So now, when we talk about these kind of rejections, we have to look at whether it is T cell or B cell. And as I said, there can be a combination of both. And BAMF 2016 has given a clear picture of what to expect when you do a biopsy of these patients. And accordingly, these are characterized. So overall, the incidence which is mentioned is around 2 to 5% for T cell, and B cell or antibody-mediated chronic rejection. Exact incidence is not known, because earlier it was thought, till 15 years back, 20 years back, it was thought that it does not happen. But with this tolerance studies, we got to know this happens, and we still are trying to find out what is the overall exact incidence. And the risk factors which I've already mentioned. So any presence of duct atrophy or pycnosis that is affecting the majority of bile ducts, or bile duct damage more than 50% of the portal tract, this is typically of T cell mediated rejection. And if you see a positive C4D staining in at least 10% of the portal tracts, and there is a DSA which is tested positive within 3 months of that biopsy, puts in a diagnosis of antibody mediated rejection. So this is the same data. Now, as I said, it is important to diagnose it early. So in early versus late, the difference is overall how much damage has happened. if the bile ducts, more than 50% of the bile ducts are gone and you see damage all across all portal tracts, that is a late. If the damage is in less than 50% and there are still some decent looking bile ducts left, it is an early rejection. And then there are how much the involvement of the artery, terminal venules, you have to look at, and only 2 or more features of these kind are present. That is how they are labeled. Just to give an impression, so if you look at this on the left side is a normal histology. This is how a normal interlobular bile duct looks. That's the artery and the branch of the portal vein. So what happens in early rejection, if you look at there is a damage to the bile duct which is happening. Artery is still looking decently well, portal vein is still looking decently well. But as the disease progresses, now it is comparing the early versus late. The bile duct is totally gone, only the scar tissue is left. The arterial changes have started to happen, and if this damage is now more than 50%, then it becomes a late. So sinusoidal foamy changes, which are typically known for chronic rejection in arterial areas, you might not see that, but the bile duct loss is a very typical feature. So foam cell arteriopathy is typically reported in the explant liver when the explant is done for retransplant, but sometimes it is picked up in the needle biopsies as well, but that is pretty rare. And what you also get is a centrilobular if you look at that cholestasis, the intralobular canalicular cholestasis, and with no ductal regeneration. So that is typical of chronic rejection. If there is a biliary obstruction, you see a ductal proliferation that happens in these areas. And the CK stain is typical. Cytokeratin stain is very specific for the bile ducts. This is how the normal bile duct would look, and on the left side is something which is a damaged bile duct, which you see on a CK stain. Now, what are the management strategies? As I mentioned earlier, try to prevent it by optimizing the immunosuppression, or if someone is suspected or there is a high risk features, as I discussed earlier, try and biopsy that and look for chronic rejection in early stage. In early stage, if you optimize the TAC level, modify, if someone is on cyclosporin, change it to tacrolimus. And there has been data which shows that if you change this treatment early, the reversal happens. If the bilirubin goes beyond 10, this reversal is unlikely to happen, and very few patients you see the reversal. So if at all you have to attack early. There is a significant role of mTOR that has been published in the literature, and if again using the mTOR gives you an advantage of reversal or stabilization of the disease if it is started early, when the bilirubin is less than 5 or at the most maximum is 10. But if it goes beyond 10, usually you don't see the response. So the predictive factors, as mentioned in the literature, is donor age, total serum bilirubin, more extensive bile duct loss, and small arterial loss. And a paper published by Medanta Group, Dr. Narendra has mentioned on that. If you start them early, you can get a reversal of 50%. And this is similar thing which is shown in pediatric population. The pediatric population, if you add mTOR, the reversibility is even better. They could see a reversibility of 77.7%, again, early diagnosis. And even in this set of patients, they could see reversal of fibrosis also happening. So important thing here is early diagnosis, modifying the immunosuppression, optimizing the immunosuppression. If someone is on cyclosporin, convert it to tacrolimus to the dose as much as possible. Add mTOR inhibitors if feasible. If someone is not having a nephrotic proteinuria, you can add mTOR inhibitors, and that helps. So as far as chronic AMR is concerned, the management strategies are evolving. The COMET group, which was actually looking at the long-term management of modifiable risk in organ transplant, they found out that if someone has a MFI of more than 5,000 and histologic features consistent with antibody-mediated chronic rejection, irrespective of the LFTs, add another agent, optimize the dose of CNI as much as tolerated. And if there is a history of autoimmune liver disease or there is evidence of de novo autoimmune hepatitis, add steroids. So put them on 3 drugs, and that helps in reversal. Now, in terms of these kind of patients who have very high MFI levels, there are various single center data which talks about using rituximab or bortezomib, but that has not been proven in a multi-center trials. But there is definite advantage of adding MMF and mTOR in this set of patients. Some centers have shown advantage of IVIG also in chronic antibody-mediated rejection. So there is some case reports which are there that in patients who have early onset biliary stricture, they tend to have chronic rejection later on as well, even when these strictures are remodeled. Or sometimes patients present on biopsy, it is suggestive with chronic rejection, and you start treatment, the things are not improving. You put in a standard and it improves. So what happens is, when there is even if non-critical biliary stricture, it upregulates the MHC antigen expression on the biliary epithelium. That is thought to predispose this kind of a situation, but it is not something which is standard of care. On a case-to-case basis, if you suspect there can be a combination of early stricturing happening, should consider immunosuppression along with stenting in these kind of patients. And early recognition can reduce the graft loss. Now, in a lot of these situations, we tend to diagnose these patients when already the late chronic rejection has happened. And in those situations, the option is retransplant. Now, if you look at the data, 33% of the retransplants are done for chronic rejection. These are multi-center data. And the problem with the retransplant in these situations is retransplant is never an easy thing technically. And then usually what happens is, since you are optimizing the immunosuppression, you are trying to salvage the graft, and in the process the patient sometimes tend to become sick, goes on ventilator, or the renal dysfunction happens, the MELD becomes very high. So we have to look at whether there is going to be a success of transplant in these situations or not. So what we actually collected the Indian data on retransplant. We contacted around 38 centers. We got data from 26 centers, and we looked at the data of around 97 re-LDLT, particularly LDLT after LDLT scenarios. And in this data, around 29% of the patients were transplanted for chronic rejection. And among all the etiologies, all the reasons for retransplant, the chronic rejection patients do reasonably well. As Dr. Soin was mentioning in his talk, retransplants done for EAD does not do that well, and that is what even the multi-center data shows. The outcome is pretty bad. Again, the reason is the sepsis starts to happen and the delay is so much. But if you optimize the patient before the patient becomes too sick, the retransplant can give you the results similar to the primary transplant. So now, what are the future things in terms of chronic rejection? There are situations when you get a C4d negative antibody-mediated rejection, which is an entity which has been recently found. And this is something which was known in kidney transplant data. And this is something we need to look at what are the other reasons for transplant. Like in kidney, now we know there are anti-basement membrane antibodies which can lead to antibody-mediated rejection like a situation. This is something which still needs to be evaluated, and we need to look for molecular signatures to identify high risk. And this is one of the study recently published. They looked at transcriptome sequencing on patients. So they have taken the biopsies from 2 major centers in Europe, and they have looked at the potential molecular markers or molecular signatures which can identify which graft is going to go into graft loss. But whether you can do it on a practical basis or not, that is still being evaluated. But this is something which has been externally validated, and this is something which we need in the coming times to look at, to identify which is the graft which is at higher risk. So we know certain risk. We should have a low threshold to do the biopsy, reinforce the immunosuppression regime as quickly as possible, and optimize the treatment so that we can salvage the graft. And if the graft cannot be salvaged, timely retransplant is going to save these patients. So I would end my presentation here and want to invite you all for Liver Transplant Society of India annual conference this year in November in Delhi. Thank you.
Thank you, Dr. Abdeep, for that excellent talk. And can we have the discussion at the end? Or yeah, sure. Please join us on the stage.
So an update is for all of you who are in this session new, like I was. We just started the session and we're 15 minutes delayed. So the next topic is by Dr. Praveen Sharma, and it is on strategies to manage metabolic complications after liver transplantation. Please welcome.
So good evening, everybody. So I will be talking about strategies to manage metabolic complication after liver transplantation. The first thing which all should follow, that prevention is always better than cure. So we should be always prepared that when we are posting a patient for liver transplant, we should look after what are those patients who will probably have metabolic complication after transplant. If we know this thing, then we have strategies to manage those patients. But let us see what we can do for our patients. So what are metabolic complications? Metabolic complications will include post-transplant metabolic syndrome, which are different factors, which includes diabetes, obesity, dyslipidemia, hypertension, MASL, and the MASH. If we go, within 2 years of transplant, if we see the metabolic complication, most of these patients, they develop one form of other metabolic complication. Metabolic syndrome will develop in about 50 to 60% of the patient, obesity maybe 50, 60, hypertension, and most of these complications will be about 50 to 60% of the patient will have one or other metabolic complication. How do we define metabolic complication? The criteria remains the standard as per the non-transplant candidate. Most of the time we use NECP, ATP3 criteria, and if you have the fasting sugar more than 110, patient has own diabetic drugs, maybe central waist ratio more than 102, hypertension. If all out of 3 criteria fulfills, means the patient has a metabolic syndrome. But why we are talking about metabolic syndrome, metabolic complications like diabetes, hypertension, other things? But if we follow all our patients of post-transplant, this metabolic syndrome is seen in up to about 60% of our patient, and the individual will be approximate 50 to 60%. But why diabetes, obesity, hypertension, dyslipidemia matters? The only thing that matters is if we follow this patient, most of these patients will have more of cardiovascular events. They are very prone to develop any major adverse cardiac risk event. So these are the patients who are prone to develop complication and mortality because of these cardiovascular events. Now let us see the impact of obesity on liver transplant outcome. Suppose if the patient is an obese and we are listing it for liver transplantation. Since the patient is waiting for the waitlist mortality, these are the patients who will have increased mortality because chances of getting a DDLT or LDLT in our scenario is less. They have increased chances of portal vein thrombosis. So we need to stabilize our patients. During transplant phase also, they have got increased morbidity and mortality, and they will have longer hospital stay. So before we make this patient, for the liver transplant, we should try to correct their BMI. Even in the post-transplant period, they have lower overall survival, they have more cardiovascular events, they have metabolic syndrome, diabetes, and SCC recurrence. So the impact of obesity is a lot. This is a wonderful study which has followed obese patient over a period of 15 years, and we can see that the overall mortality in obese patient is significantly more compared to a normal person. One thing which is very interesting in post-transplant patients, they tend to gain weight in the immediate post-transplant phase. Within 1 year, most of the patients, they gain about 5 to 10 kg. And even if we prescribe them a good diet and good exercise, this almost always fails. Nobody matters whether we do exercise, patient we are advised not to take this much of food. Most of these patients, they gain weight. And we do not have much drugs to reduce their weight. So this complication is very important, and we need to stratify our post-transplant patient. The second impact is of diabetes. If the patient is pre-diabetic before transplantation, or the patient developed a de novo diabetes after post-transplant diabetes after that. So let us see what happens to patients who develop diabetes post-transplant or who have diabetes before transplant. So this is a nationwide population-based study which have included all the transplant patients. And if we follow even the liver transplant patient or whatever the other type of transplant is, the solid organ transplant, we see that if the patient has no diabetes, then he fares better. The cardiovascular risk is less. But if the patient has a diabetes prior to the transplant or develop diabetes later on, they have more of cardiac risk factors. They have more of CVA. They have more of mortality. So, evaluating a patient for diabetes before and after transplant is very important. Now, let us see if the patient has got a transplant. A patient has got a transplant because of NASH-related cirrhosis or maybe some other sort cryptogenic. And if we follow our patient of transplant, about 3 to 5 years later on, most of these liver, they have steatotic liver disease, about 70 to 80%. And de novo NAFLD is also very common. But why this is more important? Because these are the patients who will probably have the same transplant survival. The graft survival remains the same, but they are more prone to develop cardiovascular event. So evaluating for the steatotic liver disease is very important. But how do we know which patients are going to be having steatotic liver disease? If the pre-transplant, the patient has got an alcoholic etiology or cryptogenic, or we are giving a tacrolimus for a prolonged duration of time, or they have a increased BMI after transplant. So these are the patients probably will develop complication because of metabolic syndrome. So evaluating a patient post-transplant for metabolic syndrome is important, because not for the graft point of view, but for increased cardiovascular disease after post-transplantation, which increases the mortality in this patient. So what are the factors which predispose to this metabolic complication? How do we know that these are the patients who will try to develop, who will probably develop complication, cardiometabolic complication after transplant? They could be because of recipient-based factors, maybe donor-based factors, or maybe post-transplant various factors. But how do we know? The risk factor in patient who is old, maybe 50 years plus, patient who is a male, if he has a cirrhotic etiology because of MASH or alcohol, he has a previous history of CAD, diabetes, hypertension, these are the patients who have increased chances of a cardiovascular event. In the donor, if the donor age is more, patient has a donor has a steatotic liver disease and genetic profile, means he has a PLP positive, then these are the people who probably have more of cardiovascular event. In the post-transplant period, if you are using prolonged period of corticosteroids and the lifestyle is sedentary, these are the people probably, and these are the things probably we can target. If we see which things which can target, we cannot target the age, we cannot target the gender, we cannot target the etiology. So the factor in the recipient, I think there is no way we can target and we can minimize the metabolic complications. But in the donor, probably the patient has all these features, probably we can use non-steatotic liver, we can use less advanced age donor, and we can see for the genetic profile. And for that immunosuppression, we can probably modify our immunosuppression according to the profile of the patient before transplantation. We should also know that various immunosuppression which we use has got some metabolic complication. Just to brief, if you're using steroids for a prolonged duration of time, which we are not using most of the time, these are the people who are trying to become more obese, they're trying to get more of diabetes, dyslipidemia. If you're using tacrolimus, probably they have chances of developing of diabetes. So try to avoid tacrolimus if the patient probably before transplant has impaired fasting sugar or patient is a diabetic. If the patient is hypertensive, cyclosporine is the culprit probably most of the time, and mTOR is because of dyslipidemia. We should know that these are the factors in patients who previously before transplant have this risk factor. Try to avoid this immunosuppression. So basically, which we can modify is the immunosuppression, and the lifestyle plays a key role in preventing strategies of preventing metabolic complications. So in the immunosuppression, we should know which are the drugs which probably cause more of diabetes, more of hypertension, more of dyslipidemia, and probably we try to correct the sedentary lifestyle of the person and some social problems which most of the people have. They are trying to stay in the home because they thought that post-transplant they need to stay at one particular home, that they will not get any infection. So we need to target all these points. Now, management of complications. So management of diabetes probably initially was, we say as a new onset diabetes after transplantation, know that now the term has now changed. Post-transplant diabetes mellitus we use. The diagnostic criteria remains the same as of non-transplant candidate. What are the factors which predispose to diabetes? It's almost the same. If the patient etiology is SCV, alcohol, older age group, if patient has a diabetes previous to that, hypertension, dyslipidemia. So these are the factors which probably predispose this patient to have more of diabetes, and which are transplant risk factors are also there. We should always remember and note that there are certain factors which we can modify, there are certain factors which we cannot modify. Now for diabetes, we have some drugs which are newer in outcome, like they have just come up. There are a number of, tsunami of multiple drugs which have now come up, whether they can be used in our patient who has got post-transplant. Now, we do not have enough data, but there are various studies which have shown that probably GLP-1 receptor agonist and SGLT2 inhibitors, they can be used in post-transplant period also. And these are the drugs which are shown to reduce graft steatosis, they improve renal function, and they reduce the occurrence of any major cardiovascular event. So these are the drugs probably play a greater role in management of diabetes these days. So how do we manage diabetes? The standard protocol, No non-pharmacological intervention. One should control the diet, physical activity, try to minimize steroids. We can change from tacrolimus to cyclosporine, or if you're using tacrolimus, we can reduce the dose and add on mTOR inhibitors or mycophenolate. But even if we are not able to control that, metformin is the first line of drugs. Depending upon the second line of drug, we need to understand which type other comorbid condition the patient has. If the person is having some sort of heart failure, renal transplant, it is the SGLT2 inhibitors which should be used. If the patient is obese, we can use GLP-1 receptor agonist. If we have NASH related, then we can use pioglitazone. Depending upon the third line of drug, depends upon which metabolic complication this person is having. Now, how can we prevent obesity in our liver transplant patient? Pre-transplant, we need to focus on that. Diet and exercise remains a corner point. We should always see for the cardiovascular risk assessment, evaluation for and treatment of obesity-related complication. Medical and sometimes the bariatric surgery may be in patients with compensated liver disease, sometimes can help. We have some endoscopic method also. We can put a balloon and to reduce the weight, to reduce the BMI of this patient. At the time of transplant, some of the people, they are using bariatric surgery simultaneous to liver transplant, so the data is very scanty, and we can prevent ICU infections. Post-transplant, we have immunosuppression management, which is very important, treatment of metabolic profile, and bariatric surgery sometimes after transplant is also helpful in patients who have got a grade 3 obesity. Important thing is sometimes, obese patient, we try to restrict their calorie intake. We say, okay, do not take any calories. The important point is not just the calories, it is important, the overall nutrition is important. We need to make up the muscle mass and we need to improve the protein component. So it is always better to give maybe 25 kilocalories per kg for this type of patient and increase the protein to about 2 to 2.5 grams. And exercise remains the corner point. Physical activity is very important. Pharmacological treatment, we do not have much pharmacological treatment in cirrhosis patients who are decompensated. But in a compensated patient, sometimes we can use liraglutide. Now even semaglutide has shown some benefit in cirrhotic patient also. Bariatric surgery sometimes can be used in compensated patient. I can skip this. Now, how do we manage hypertension? I think there is nothing which is very significant for the control of blood pressure or hypertension in patient post-liver transplant, but calcium channel blocker should be the first line of management. If the person, even after first line or second line, that is ACE inhibitor or ARB inhibitor should be the second line. We can use beta blocker in certain patient, but switch over to tacrolimus if the patient is taking cyclosporine. Try to minimize steroid. Weight management is very important, and regular exercise and avoid salt remains the cornerstone for the management of hypertension post-transplant. Similarly, for dyslipidemia, it's almost the same, but try to use statins, which are pravastatin remains the first point because it has got less interaction and less drug-to-drug interaction. If the patient has not responded to that, we can use on second drugs, which remains the same. If the patient has got an increased triglycerides, try to give omega fatty acid, fish oil. If not responding to that, we can add on spheric acid. If the patient is on tacrolimus, we can, if the patient is cyclosporine, we can switch over to tacrolimus, or on mTOR inhibitors, we can switch over depending upon what type of response we are getting by treating the patient with dyslipidemia. So what are the common strategies? I think pre-transplant measure to reduce weight, sarcopenia during the transplant waitlist time is very important. Try to maintain the blood pressure and glycemic control, the second point, to improve the post-transplant outcome. Thorough assessment of cardiovascular risk factor is very important. Implementing protective measures for renal function in patients with kidney dysfunction. And if possible, try to identify younger donor without cirrhosis. And in the post-transplant, just to summarize, in the obese, almost lifestyle risk factor is important. Steroid cessation after early post-transplant is very important. Try to use MMF or mTOR. Pharmacotherapy, sometimes semaglutide has shown good role. Metformin can be used. Pediatric procedure or some endoscopy procedure can be used before and after transplant also. Dyslipidemia, the standard treatment. The best thing which we can do is the dietary modification, exercise, early recognition of metabolic components, and appropriate modification of immunosuppression remains the key point in management to reduce metabolic complication post-transplant. Thank you.
Thank you, Dr. Sharma. Please have a seat. Those of us who freshly joined into the room, please note that the first speaker was actually from the last session, so we are delayed by 15 minutes. We'll try to keep on time. It's my pleasure to now welcome Dr. Bajaj, who will speak to us on long-term neurologic complications after liver transplantation.
Thank
Dr.
you.
Bajaj, welcome.
Thank you to INASL and ILTS for this kind invitation. So it's not okay. So why is it important for us to know the long-term complications? Because HE, which is what really drives most of this, causes severe disruptions. There are more HE episodes, more likelihood of residual cognitive impairment. That is even before the liver transplant has occurred. The population right now in most of the world is older, and maybe there's a lot more dementia and mild cognitive impairment. And if you look at the literature, there's an increasing recognition of the liver as a central driver of Alzheimer's disease. Recovery from HE post-LT is critical for self-sufficiency because we are not only doing a liver transplant to just fix the liver, we are going to make the patient the best possible person they can possibly be. Post-liver transplant brain dysfunction could also be affected by intra-op, peri-op, and immunosuppressive therapies. And long-term change may be much more important than the short-term cognitive changes where we can actually quickly manage them. So these are the three villages for HE. HE is not just hepatic and brain. There's the village within. All these organs have have dysfunction. Then you have the village that is affected, and the village that's required to manage HE is right here. And if you look at right here, there's every single person that you can think of in the hospital. And from now, what we're talking about is the post-liver transplant specialist as well. So obviously, we have patients who have all these conditions going into their brain, which they bring to the transplant. During the transplant, there are fluid shifts, ischemia, reperfusion, a lot of things that we already know about that also make the brain very vulnerable. This brain is already vulnerable, but then it's exposed to all of these other things. Early, infections, immunosuppressive drugs are the major drivers of cognitive impairment, whereas late, it's early complications, plus recurrence of disease and obesity that add on to the early complications as well. So what we want to look at in patients with liver disease, there's an astrocyte neuronal complication. Then you have these in senescent, which is older, swollen, and Alzheimer times 2. This actually, unfortunately, goes into neurodegeneration. We've been taught for a very long time that hepatic encephalopathy is a reversible disease. That is absolutely untrue. The more HE episodes someone has, the much more likely that this person is not going to recover even after a liver transplant. It's the extent of the recovery that we actually need to figure out. Whether we think this patient has dementia to the point that they're not going to recover, or whether this is hepatic encephalopathy to the point that they will recover. So what are the neurological complications that can happen? These are for any kind of surgery, but these are patients with cirrhosis are much more prone to. What is specifically important for cirrhosis are all of these conditions. But you can see these are syndromes. These are not diagnoses. These are symptoms of one of those things. So what our problem comes? Is it hepatic encephalopathy? Is it patients with cirrhosis with immunosuppressive problems? Or is it something completely unrelated? Or more importantly, a mixture of all of these conditions? So the burden of neurological complications is very different at 1 month and at 6 months. 15% of people have an early neurological complication that goes from CNS infections, stroke, seizures, metabolic encephalopathy as well. And later is 30%. So 30% of your patients with cirrhosis will have some kind of neurological complications late after liver transplantation. And this is really a problem because if we do not manage it, the patient is not self-sufficient. The patient will have problems going on to the other metabolic conditions, as Dr. Sharma mentioned, and that can also affect the brain as the liver disease recurs or the patient has cognitive impairments afterwards. So impaired liver transplant cognition is also associated with a poor quality of life. This is the sickness impact profile. A high score is as bad and a low score is good. What it tells you right now, in people whose cognition improved, which are in the white, the sickness impact profile post-transplant was lower than in patients whose cognition remained poor or there was an initial worsening of the things as well. So what are the determinants of recovery and prognosis? So as I said, more HE episodes lead to more impairment, but not everyone with HE or cognitive impairment will develop all of this. However, if you talk about a patient who has a very good reserve of the brain, they can withstand multiple episodes of hepatic encephalopathy but still not have cognitive impairment. And what does that mean? People are born with brain sizes which are higher, but they also, how they take care of their brain or how their socioeconomic status is, childhood cognition, education, occupational and leisure activities, higher socioeconomic status actually protects the brain. So they can withstand a lot more insults than someone who doesn't. So if someone has lower education, poor social support, lower socioeconomic status, and alcohol-related etiology, they by definition will have a low reserve. High reserve is the reverse. The impact of any insult, pre or post-transplant, will be felt much more in the low reserve patients than in the high reserve patients. So there is no blanket yes and no. You have to ask each and every patient, but people with the low reserve will more likely be very susceptible to post-LT and pre-LT cognitive problems. So how do we check for it and predict the outcomes? So clearly we can see the patient's mental status and prior HE status. We can do cognitive function before and after. Routine brain imaging is really not very helpful. Specialized brain imaging has not gone beyond research yet. And other biomarkers such as microbiota structure and function can also be related to this. Let's talk about neurocognitive testing. It is very complicated. It's not something we do normally in our patients. But in patients with hepatic encephalopathy, especially when you have a doubt whether this is dementia or hepatic encephalopathy or both, you should try and refer them to a neuropsychiatrist and figure out whether they have memory problems. If they have predominant memory problems, that is much more likely to be unrelated to cirrhosis and much more likely to be dementia related in that patient population. And that is not going to recover to a substantial extent after liver transplantation. So the current studies have been look at the sample size here, ranging from 20 to 50, 65. And the time period also ranges from 1 month to several months. But these are not really huge because every center does a finite number of liver transplants. But new onset cognitive dysfunction also represents quality of life. So this is someone who's actually completely normal going into a liver transplant. And after that, there's a new onset cognitive impairment, which is very different from the people who already had something and now have something else going on. So what happens, again, as I said, alcohol-related patients are more at risk, recalling the concept of brain reserve. The brain you go into a liver transplant with substantially determines what you end out after the transplant. It is related to visual, spatial, and language subscales. Language is usually not affected by covert or minimal hepatic encephalopathy and can progress up to 12 months post-liver transplant. This does get better over time. This is post 6 months, and this is post 12 months. The patients are feeling better, they're cognitively better, and things start getting better in almost every single thing. If you look at the R-bands, which is a global functioning analysis which has dementia as well as non-dementia studies as well. So it can take a little while for these patients to get better after a liver transplant. So the important thing to ask the patients are, what are your expectations after a liver transplant? And not just the patient, their caregivers as well. If they were never able to solve the New York Times crossword before, they're not going to be able to do that after. However, if you feel that this patient is demented, then that patient should not be a transplant candidate, and you need to think about other reasons. What are specialized brain images that you can actually do in patients you are truly in doubt? Honestly, in my practice, it's less than 5% of the patients that we truly have a doubt that what is going on with these patients. And in those people, we do other specialist MRIs such as MR spectroscopy, which is normal in healthy brain. In HE profile, because of the ammonia, these things are swollen, and there's a specific profile that people can see in the brain. In the altered brain without HE, it's normal, and with HE, again, the HE profile. But the thing, right, diffusion tensor imaging is very different. It's a detection of connectivity, and it's marker of the cerebral issue. So these are things that you can do. Most people will not need this, but it is important for us to realize the more brain that you take care of before transplant is the better brain that you'll have after transplant as well. Again, alcohol, the post-MR, brain structure, the brain reserve again with alcohol is worse. So patients with alcohol are particularly vulnerable to all these changes, and those are the people who should be monitored the most in this population. Especially, we do a lot of transplant right now in alcohol-related hepatitis in the United States. A lot of those patients are very young, so they are able to sustain a lot of these brain reserve issues. But the older patients with the alcohol-related hepatitis, they're the most at risk for these post-transplant things. These things also reverse. The post-LT functional MRI also reverses after liver transplant. So this follows what the cognitive testing and what the patients are feeling. These are three related but not the similar concepts. One of them is cognitive testing, the second is the brain imaging, and the third is how the patient is actually feeling and functioning. These usually go together, but not always. Whenever it's in doubt, we always want to figure out how the patient is feeling and functioning, because if they are able to come back to what they were before, then who cares what their brain MRI shows at this stage? We want to actually follow their functionality afterwards. Microbial diversity does get better after liver transplant. This is the diversity, which means, as the word suggests, the number of different kinds of microorganisms the patients have in their stool. These are healthy controls. This is the same person's pre and post LT. It goes better. It's not the similar to liver transplant to the controls, obviously because the patients are on immunosuppressants. The bile acid changes. I'm not going to go over the details, but this is not just the structure of the microbiome, but it's also the function of the microbiome. And ammonia also goes down with the cognitive impairment, and the PAG, which is a metabolite of ammonia, also goes up, which means there is more ammonia excretion in patients after transplant than before. Now, here is something which is very interesting with the microbiome, brain, and what Dr. Sharma was saying. The microbiota produces things such as TMAO. This TMAO requires a functioning liver. In a patient with cirrhosis, this actually also causes atherosclerosis. So in a patient post-liver transplant, this TMAO goes up. And you're like, what is that? Why should it go up? The question is that the liver was not functioning before. The last step of TMAO generation requires a functioning liver. However, beyond 6 months, when the metabolic syndrome actually takes over, we believe this is one of the main things that drives all of this, and then affects the dementia in the brain and also the cognitive impairment in these patients. So this is really an interesting thing that ties all of these things together. And with the study that we had done, the patients whose cognitive impairment, patients who had either new onset cognitive impairment or whose cognitive impairment did not get better, they had less of the beneficial bacteria and more of the non-beneficial or the pathobiont bacteria, such as people who have, such as proteobacteria, like E. coli and gram-negative rods. So ultimately, what do we do to prevent post-transplant neurological and cognitive dysfunction? We want to counsel in patients and caregivers extensively regarding reversal of pre-existing HE and new onset cognitive alterations. People want to know what they're getting into, especially in patients who are getting a living donor transplant. You really need to put this down in very much detail. Treat hepatic encephalopathy very aggressively and prevent recurrence. If you have to embolize SPSS, please do that. You want to slowly correct hyponatremia to reduce demyelination. Ensure dementing process are excluded pre-LT. There should be an early suspicion of CNI-related neurotoxicity post-LT and switching medications early, and consider using some of these specialized biomarkers. So in summary, neurological changes are seen in a large proportion of patients post-LT, which have major impacts on quality of life and daily function. Cognitive impairment and brain reserve, which means individualizing this for every patient rather than simply saying this person had prior HE, are major determinants. Changes are most pronounced within the 6 months and usually stabilize and improve over time. However, a group of people will develop a new onset cognitive dysfunction, which are associated with CNI use and can be improved with switching. Specific biomarkers related to imaging, microbial function and composition change with the course and can be used to predict outcomes in a research setting. These are my acknowledgements, and thank you for your time.
Thank you all speakers for the wonderful talks. Organizers, do we have time for questions? We can take maybe one question in the interest of time. Yes. All right. Thank you all speakers.
Thanks to the chairpersons and the speakers. Please join us for a photograph.